Welcome to this webinar covering the CTSNet guest editor series on the cardiac and congenital surgery topic, Insights into Pediatric Mechanical Circulatory Support. Thank you for joining us. Please note this webinar is being recorded and will be available next week on ctsnet.org and CTSNet's YouTube channel. At this time, I'm pleased to introduce the guest editor leading this series who will be moderating this webinar, Dr. Sandeep Sainathan. Dr. Sainathan most recently served as Assistant Professor of Surgery and Surgical Director of Pediatric Heart Transplant and Mechanical Circulatory Support at the University of Miami Miller School of Medicine. Thank you for joining us, Dr. Sainathan. I'll turn the panel over to you.
Thank you, John, for the kind introduction. At the outset, I would like to thank the audience for taking time today to explore the series with us. I'm also thrilled to introduce an international group of congenital and pediatric cardiac surgeons who are experts in their field to share their experiences with us with pediatric mechanical circulatory support. So starting off, we have Dr. Erwin Bishnoi, who is a clinical assistant professor and a congenital and a pediatric cardiac surgeon at Stanford University in Stanford, United States. We have next is Dr. Biniwale, Reshma Biniwale, who is an associate professor and a congenital cardiac surgeon in the Division of Cardiac Surgery at UCLA in Los Angeles, United States. We then have Dr. Eghtesady, who is a professor and chief of pediatric and congenital cardiac surgery in the Division of Cardiothoracic Surgery at Washington University School of Medicine in St. Louis, United States. We then have Dr. Michael Marr, who is an associate professor and chief of pediatric cardiac surgery at Stanford University in Stanford, United States. We then have Mr. Nagarajan Muthialu, who's a consultant pediatric cardiothoracic surgeon and lead for thoracic surgery at the Great Ormond Street Hospital in London, United Kingdom. We have then Dr. Daniel Zimpfer. He's the chair of the Department of Cardiac and Thoracic Aortic Surgery at the Medical University of Vienna in Vienna, Austria. And finally, we have Dr. Alsoufi, who is a professor and chief of pediatric and congenital cardiac surgery at the University of Louisville School of Medicine in Louisville, United States. Today's plan is to first have a discussion, an individual discussion with all of our panelists, 6 of them. I encourage, if the audience have not seen the videos, I'd encourage them to go and see these videos. These videos were posted on CTSNet the week prior to the webinar. The webinar focuses on surgical nuances in pediatric mechanical circulatory support, and the questions range from varying levels of expertise so that we can sort of involve all participants with varying levels of familiarity with them. I will start off with Dr. Eghtesady. Dr. Eghtesady and Dr. Miller presented a video using the Berlin heart for supporting an infant with a failing univentricular circulation after a Norwood procedure with a systemic to pulmonary artery shunt. Dr. Eghtesady, I have a few technical questions. In your experience, you tend to do these procedures without any extracorporeal support. How successful are you most of the times?
Thank you, Sandeep. First of all, I'm grateful to be part of this esteemed panel. With regard to your specific question, I would say it's probably about somewhere around 50 to 60% of the time we can do it off pump.
Sure. And you present a very other novel form of support, which is ECMO. So that cuts down your need for anticoagulation. Any concerns with ECMO, especially while sort of inserting the inflow cannula on the atrial side, for any concerns for air entrainment? Do you take any precautions? And also, do you direct the cannulas in a specific position so that that risk is avoided?
Yeah, so you're absolutely right. And the key part of it is making sure you have no air entrainment during implantation. You know, if you have a side biting clamp on the common atrium, it's relatively easy to ensure because you know there's a fair amount of volume there, and when you connect in the process, you can make sure the system is completely de-aired. If you're doing it with a stab and go technique, similarly, it's kind of like similar to bypass, where again, when you insert the cannula, especially with the if you have using the Berlin atrial cannulas that has a bit of a length, so it makes it a little bit easier. Once you put it in, we typically put the head down. Make sure the tricky part really is once you've passed the cannula up through the abdominal wall. At that point, you can no longer lift up the cannula. So you have to make sure prior to that you've done a good job de-airing, and then once you connect it, it works out fine.
I also noticed, Dr. Eghtesady, is that also among the other presenters, there seems to be a lot of variation as far as the arterial cannula is used. You tend not to use the right angle cannula, and you tend to use a straight, rather an apical cannula with a Gore-Tex interposition. Anything which you would like to share an experience in as to why that sort of modification?
Sure. Historically, used to use that as well. And then the challenge was, particularly when you're dealing with small spaces, the sewing ring of that right angle cannula is obviously stiff and doesn't have a lot of room. And, the first thing, I mean, this is going back to honestly, shortly after Berlin, when we started doing Berlin in general, we started using the interposition graph on the cannula with a right angle cannula with a short segment. What I notice is that short segment can sometimes kink. And I'd had an occasional patient that had some degree of hemolysis that was associated because of, I think, just having to go back in to revise that because it was effectively not sitting appropriate geometry once the chest was closed. So that's when I became interested in, ironically, the very first single ventricle or SVAD that I did, for somewhat similar concerns. I used the homograft tissue that was attached to the apical cannula. So it was we took basically a pulmonary homograph and sewed it to an apical cannula, a small baby, and then attached that to the ascending aorta. But the homographs are so expensive and it didn't make sense. It was extremely hemostatic, but that's when I decided to use the Gore-Tex tube graft instead with the apical cannula. And it makes it super easy because you make your composite graft. You just have to get a good sense for the distance, the length, because the Gore-Tex can stretch. But then once you do your anastomosis, particularly if you're doing it off pump, it really makes it a lot easier. Then you can tunnel it out. And it's somewhat more forgiving in some ways, I think, because you have a little bit of flexibility in it. So that's why we started doing that. And we've been doing that for a long time.
And I have a sort of, just to using the segue, I have a question for Mr. Muthialu. I noticed that the outflow graft in his video is somewhat special with in a special clip, and it sort of comes integrated. Is that something which you have modified in Great Ormond Street, or it comes commercially?
It comes commercially, but I think we were involved in the discussion in the initial part itself. It comes commercially as a pre-packed set.
Okay.
And it's quite comfortable to use them. In fact, if you just follow once how to do them, it's quite easy to do that. And it's very handy. Though there are initial nervousness as to whether the graft and the cannula will sit together, whether this one will impinge on the organs inside, and whether there will be any impact from the metal bed. I have not seen a real trouble related to those things.
And your video also showed a sort of a plastic scaffold to protect that. Is that also comes
Correct.
commercially with that? Okay.
Yes. In fact, if you see the scaffold has got a very specific orientation in order to cover the metal bed, and then it sits on the graft, and it's an adjustable length. It's quite a long scaffold that they provide. You can adjust the length and then sit. But remember, our graft will be curved starting from the sub cardiac area, diaphragm area, to reach the aortic sidewall of the aorta. That means the graft will be curved. So the scaffold will be too stiff. So it needs to be adjusted and then tied over in order to maintain its position.
And I know, many surgeons still use a Dacron. Is there an opinion for or against it? I had one situation where we had to, like as Dr. Eghtesady was pointing out, we had to change from Dacron to Gore-Tex because we were having hemolysis. So any, again, because it just handles well, and that's why it's sort of It's easy to use as compared to Gore-Tex. Any opinions for or against it? Anyone has any other personal experience?
I have used both, and I didn't see a particular problem of hemolysis using Dacron. Sometimes I do come across weeping of the graft, contributing to sometimes collection, hematoma, or more like a seroma collection around the graft. I've explored at least twice in the past, about a few years ago, where there was a serous collection and we needed to relieve that. But other than that, I have not seen a problem related to the graft, and I would prefer a graft rather than olden aortic cannula where you need to put that cuff directly onto the aorta is a very cumbersome. Hemostasis is quite tricky. So grafted ones are far better.
Sure. And again, back to Dr. Eghtesady. I also noticed that you support the patient initially with a centrifugal pump and then sort of transition the patient to a Berlin pump. Could you share your rationale for that?
It's a couple of fold. One is the fact that I think sometimes these babies early on need a lot of flow, a lot of support. And instead of, going with because on occasion we've had patients, we didn't always do that. We had initially, I think, gone honestly to just Berlin. And then there were times that we would end up struggling because the child was inadequately supported. And then we would end up having to switch to Centromag. And it became very costly. So by doing it the other way around, starting with Centromag, we could effectively find out what the child needs in that early period. And then from there, we can transition to the Berlin. So it sort of makes it a little bit easier. And I think the kinetic assist you get from the Centromag makes it, I have to be careful about the words that I use, makes it ICU safe for that first early period, just because there may be some challenges in terms of managing the patient, etc. So that's
Sure.
part of the rationale.
And as you pointed out, like you tend to flow higher for single ventricle patients than a patient with a biventricular circulation, and it's more conducive to flow higher with a PDMAG device initially. And also your video pointed out to always look for collaterals and a lot of wasted circulation as the kids are supported. And how often do you cath them, or do you cath them based on clinical needs when they're supported for a prolonged period of time?
We do it based on clinical need. It's not a question if they have collaterals in these kids, they all do. It's just a question of the extent that they do. I have to admit, sometimes I've been really shocked or surprised by the amount of flow or support that we're providing for some of the infants to ensure that they're doing okay and managing to move forward. It's counterintuitive, or it's not totally obvious to me why they would require sometimes cardiac index of like 7 or something, some ridiculous number. This is something we have discussions with our cardiology colleagues, because their thought process is that the minute you coil a bunch of these collaterals, a bunch of other ones grow like right out. I don't think that's truly the case. They can be quite extensive, and I do think that once you take out some, perhaps others may become apparent. But I am biased, and I think it makes for a much safer transplant, an easier transplant, when as much of the collaterals are taken out. So my preference is to have them be aggressive, and even if it means there are several hours in the cath lab, to take out as many of the collaterals as they can.
Sure. And do you always prefer atrial cannulation for the inflow, or do you consider ventricular cannulation at times?
I have to admit, in the last 15 years, I don't think I've ever done a ventricular cannulation for single ventricle kids. And the rationale is, I'll share with you, I think, first of all these kids, I've never had problems. As long as you're careful about the atrial septum, I've never had trouble or problems with adequate filling or having the cannula be positioned appropriately. You do have to keep it in consideration the relationship to the atrial septum, and making sure you're not putting it such that, for example, it's really high up, like going straight to the atrial appendage, and you end up having the tip of the cannula, abutting the atrial septum potentially. One, you have much less dissection, which means much less oozing and bleeding afterwards. Lesser likelihood of having to deal with challenges with recurrent adhesions at the time of the transplant. And then frankly, you still, if there is any injury that occurs to the heart during the process, you could diminish the potential for native cardiac output. I never bother, and I've always done from babies to Fontans. I've always done just atrial cannulation. I'm biased about doing that.
And this was my follow-up question, actually, was if you would modify your technique, someone who had a superior pulmonary anastomosis done. And also, what would be your technique with someone who's unpalliated after hyperplastic, with the hyperplastic left heart syndrome, who sort of needs support from get-go?
Your second question, done basically concomitant with the hybrid procedures, and we publish this. We just basically do a VAD right off the bat into the MPA and RA, and those are in some ways the easiest cases because you can do them completely off pump and it makes it a lot easier for the kids. You open up the chest, put your bands on, you put your which makes the kids a little bit more stable, and then put the put your cannulas before we introduce the apical there. We use the graft as a means of introducing the PDA stent, which makes it a lot easier for not having to worry about how deep the sheath goes. Your first question with regard to Glenn's, we have, knock on wood, we've had reasonable success. I think it's the selection of the patients to some extent. If the baby is really hypoxic coming into it and it's not related to cardiac output issues or, essentially adequate delivery of cardiac output, and it's more with blood flow to the lungs, and you can determine that fairly quickly depending on how sick they are. I think sometimes you may need to use an oxygenator in line for the first few days to get them through, but if they're still struggling after that, I think the thing to do is to put a BT shunt in them if it's an issue with oxygenation. Otherwise, you shouldn't have really any trouble with flowing the VADs, and we have done okay, and we haven't modified. It's still been atrial to aorta for our GLEDs as well.
Sure.
I know
There's so much-
historically that's been a challenging population, but that has not been our experience.
Sure. There's so much to ask, Dr. Eghtesady. In the interest of time, I'll move on to the next discussant. I have Drs. Ma and Dr. Bishnoi from Stanford, who had presented their technique of Berlin VAD implantation in a patient with a restrictive cardiomyopathy with biventricular hypertrophy, and they used the biatrial technique for inflow cannulation. A few technical questions here as far as nuances are concerned. Both Dr. Ma and Bishnoi, how do you size the Gotex, and always has to be a ringed Gotex?
So the size of the graft depends upon what size of cannula we are choosing. Most of the time, this biatrial technique we use, these are smaller kids. So we have used a 6 millimeter cannula for the atrial cannulation. And we take a 2 millimeter larger graft. For 6 millimeter cannula, it is 8. And if it is 9 millimeter cannula, then we take for 12 millimeter graft. We have not used more than bigger cannula, that like 12 millimeter cannula, those are bigger kids, and they do not require this technique. This kind of technique is basically used most of the time in restrictive cardiomyopathy, hypertrophic cardiomyopathy, or in any patient where we are doing a VAD as a bridge to recovery, where it's easier to take it down.
It preferably has to be ringed. That's your preference always.
Yeah, ring graft, we saw in few of the cases, like when you put a without ring graft, and because it is on the inflow of the VAD, and VAD has a negative pressures. So if there is any problem with venous drainage, we saw that it sucks in the graft, completely collapses. So that's why we started using the ring graft. And after that, it is fine.
And again, a bit of a clarification. What cannula are you using for engaging into the graft? Is that like a venous cannula or an arterial cannula?
We are using arterial cannula for that.
Arterial cannula. And you
Yeah,
sort of
angled. Yeah.
Sure. And then also a bit of clarification, the bevel is kept in such a way that I'm assuming is to keep it as low as on the septum for the LA cannula. Is that correct?
Yeah, so we use the same principle like sending procedure, where we are doing that whole flow comes posteriorly. So we
Okay.
keep our bevel, that the toe end goes towards the I will say toward the tricuspid valve, and the bevel end goes towards the right pulmonary vein. We have been using like this technique only, but I think if we do it other way around also, it should not make much difference there.
And also, like maybe in the video for the brevity, you may have skipped it. So you have to seal the atrial wall around that cannula. Is that correct?
Yes, that part can be tricky because it is a ring graft, and the rings are spiral around the graft. So if you look at the circumference, at least at one point, the suture line has to cross that ring on
Sure,
the
sure,
Gore-Tex.
sure,
So
sure.
we take a superficial bites on the partial thickness bites on the Gore-Tex, and they take a full thickness graft on the atrial tissue. And at the site where we are crossing the ring, we put an additional intrepid suture there to seal it. After that, we fill up the right atrium and look for any leak there. If there is any leak, before putting the right atrial cannula, we fix it. Otherwise, it can be challenging.
Yes, that's the trick. And also in your video, you had mentioned that you use both RA and LA pressure catheters as a guide. If you can just expand on a little bit, and how do you like titrate the pump settings and flows based on that?
Yeah, my chief, Dr. Michael Marr, will deal with that question.
Yeah, I can chime in. Thanks for having us, obviously. I mean, we assess all parameters anytime we put a bivad in or a single vad. So we have combination or we have biatrial filling pressure lines whenever we put both devices in. Our objective is obviously to achieve as much systemic and pulmonic cardiac output as possible with the lowest filling pressure. So we want both filling pressure lines to be low, and when one VAD is either underfilled or overfilled with the other one not working, that's when we know there's a problem. And we typically keep biatrial lines in for the first several days until we've really finally titrated the devices so that we feel comfortable with their function. We almost never run the RVAD near capacity. We've had situations, and I'm sure all of the people on this panel have had this problem, but we've had situations where we've overrun the RVAD and the pulmonary circuit is not that compliant, so you end up flooding the lungs and having a major problem, and then that's a disaster. So I think the maximal amount of RVAD flow we've ever used in any type of BiVAD configuration is maybe 70 or 80% of the LVAD flow.
And again, just a little bit of clarification, where do you bring these catheters out so that you don't have any issues of bleeding and other issues when you pull them out a few days down the,
I can't recall a situation in the recent past where we've taken out an intracardiac line and actually had to re-explore a patient. We've certainly had situations where the chest tube output has increased for a few hours afterwards, but it's always been pretty hemostatic. I would say the closer you put the intracardiac line to where the inflow is, the less reliable it is. So typically when we've used inner atrial septal implantation of the LVAD cannula, we will place the intracardiac line in the LA appendage, which is as remote a position as we can place that. And then for the RA, we will usually use maybe a spot really close to the IVC, sometimes where we had previously done the bicable cannulation for the BiVAD implant. And that's as far a location as can be from where the RA appendage inflow of the VAD would be for a typical BiVAD configuration.
And another clarification is how do you orient the cannulas on the abdomen, like when you're trying to tunnel them? Are they any different? Because both of them are coming on, on sort of on the ipsilateral and the atrial side. So do you bring them or you cross them, or any techniques as far as orientation of the cannula on the abdomen is concerned?
We try to keep things as parallel as possible. We almost never try to cross cannulas because then it becomes very confusing for ourselves and for our ICU colleagues as we try to do pump exchanges when necessary. We spend a lot of time planning the cannulas because sometimes we are thinking about recovery, sometimes we're thinking about putting in biventricular pacing devices. So I almost will always want to consume only one side or the other when possible. Typically for a BiVAD configuration where the inflows are all atrial,
and you have a levocardic patient, I would try to site all of the cannulas in the right abdomen as far away from the incision as possible to reduce infection risk and also give us some real estate in the left chest or the left abdomen in case we want to put a BiV pacing device for bridge to recovery.
I also noticed in your video that you're not using an interposition graft, you're rather anastomosing the atrial cannulas directly to the great vessels. If that's what I may have seen, I think you don't put an interposition graft, right? You put you use a sewing cuff on the atrial cannulas and then sew it directly to the vessels.
Whenever we do any interposition graft on whether it is a left atrium or the aorta, it gives a lot of length to the whole system. So if you are putting a chimney on the left atrium and then you're doing a right atrial cannulation and putting a chimney graft on the aorta also, end of the procedure, you will see that all those three cannulas are sited at the similar position. So it becomes very difficult for these three cannulas to take it out parallelly. After, if we have chimney on the left atrium, our LA cannula will come on the right side first cannula. Then the adjacent to that from right to left, if I come the next cannula with the LA cannula, sorry, right atrial cannula, and then comes the aortic cannula and then the PA cannula. So that's why we try to put aortic cannula directly. Yeah, it comes with some disadvantages that, as Dr. Firoz said that previously, the hemostasis is a problem with that. So now we sometimes put a donut or pericardium between the suture line, so then it makes it more hemostatic.
One simple trick that for BIVAD patients, we've 3D printed the Berlin cannulas, and we put, after looking at the CT scan, if you go to this is particularly helpful for babies because for older, bigger patients, there's a lot of space, there's less issue, but it really is helpful, particularly if they have, for instance, an infant that has a G-tube or something like that. For preoperative, just hold it against the chest wall and you can get a really good sense of the spacing and distances, things like that. So that would be one thing I would suggest to folks out there.
Sure. Thank you so much, Dr. Eghtesady. And the final question I had was, there are some groups who recommend ventriculotomies or ventriculectomies if they're not thinking about recovery and then supporting these restrictive cardiomyopathies by modifying the implants of these BIVAD devices. Any opinions or any experience among the panelists for that?
We have not done at this center that technique. I have seen the videos of that in some of the conferences. Yeah, it sounds interesting to excise everything and put a Berlin cannula there, but it comes with its own disadvantages. Obviously, there's no valve there. And second thing is, biggest concern on our side is that whenever you put a Berlin, the pump change is a reality. Many times you will see the clot there, then you have to do a pump change, and then it can be a very, very difficult issue.
Again, so thank you so much, Dr. Bishnoi. I would ask Mr. Muthialu, who had presented use of the Berlin in a bioventricular circulation for support and their extensive experience at the Great Ormond Street Hospital. A few questions which I have. First is Mr. Muthialu, any tips how to site where you're going to place the apical cannula and the LV apex, especially if it's morphological LV, and then any changes you would do if it was a morphological RV?
Quite an interesting comment. Yes. We haven't done a corrected transposition morphological RV support in any form. So usually systemic ventricle, let's limit to that. But it's useful to identify LAD as our landmark in order to find where the septum is. It's also important to have TOE on table. So what we normally advocate, and it's useful for many of the VADs, whether it is implantable durable device, whatever VAD it is, it's very simple maneuver of putting your finger, index finger, parallel to the septum, just lateral to the LAD, and looking at your TOE to understand where the finger directs to. It's not only for the cavity, and it is also for the direction. It's very important to know that. And that's better facilitated when the heart is not fully emptied on bypass. Leave some volume inside, don't empty the heart completely on the vent, and then put your finger there, look at the images and see how the finger lies. And that's the direction of the cannula, and that's the point of cannulation. And then I always take a stay suture at the point where I put the finger in, lateral to the LAD. it doesn't really matter what happens to the LAD. This ventricle is going to be thrown into the bin. We don't have destination therapy or bridge towards recovery in pediatrics anyway. Most of these children are supported, or almost all of them are supported to bridge as a bridge candidate to transplant. And in fact, many of these children's sutures will be on LAD itself, because as I mentioned, the stay suture will be right lateral to that LAD point on the most projectile part of the left ventricle, so the systemic ventricle. Once I put the stay, I take a core out of it, and the core goes to the histology just to make sure that we are correct in our diagnosis. We can subject them to special stains. Occasionally, it comes as chronic lymphocytic infiltration in the myocardium, and you can always remotely think whether this is a myocardium that will recover at some point in time. We had weaned off 7 candidates so far in our experience and explanted those volume parts. So that's not our main aim, but that's useful to review them later at some point in time. And then, as I said, the finger, again, that is the direction your cannula is going to sit. Now, the Berlin heart apical cannula has got a bevel. Now, the question is whether you want to keep the bevel towards the septum or towards the free wall. And there are 2 schools, and there is no right or wrong answer here. As long as your cannulation, the orientation of the cannula is parallel to the septum, it doesn't matter where you keep. I'm still a traditional man. I orient the bevel towards the septum, not away from the septum towards the free wall, but nothing wrong in that. Some of us practice keeping it to the free wall. At the end of the day, if the cannula sits parallel, it will not be sucking either of the structures into the cannula, causing trouble. And in our experience, we have only come across once where we had to change the orientation. The mistake happens when there is always in a globular dilated LV, and if you're not careful, you tend to go slightly more lateral, and then it becomes angulated cannulation to the LV cavity, and the tip is now closer to one of the structures, either the free wall or the septum, and that's when all these things happen.
Sure. And do you always fibrillate the heart, or when you're doing the apical coring or the cannulation, or at times you can just do it, the ventricle contraction is so poor and the aortic valve is not opening, and you could potentially do it without fibrillation?
During my training period, I was told this heart is going into the wind. What are you going to do by doing something? But I am quite controversial in that way. I always give a cardioplegia. One is cardioplegia gives the heart complete rest, and I have a vent so that the heart is empty and rested nicely, flabby. That means I lift the heart, use 6x4 swabs down, wet swabs below so that the heart is supported. That means I take the core, no second hand holding the heart there. I take 2 stitches at 12 o'clock and 6 o'clock and secure the cannula in position, and then run through interrupted pledgeted sutures to fix the cannula. It takes probably less than around 10 minutes or so for apical cannulation, and then tunneling happens after that. So my choice is cardioplegia. The reason is I need to protect the little bit of a myocardial cell function for the RV, and I do my best to see what I can do to support the RV and avoid a BIVAD in most of the situations. Because as we know, the survival and complications and morbidities are almost double or a little bit more than that in a BIVAD as compared to LVAD alone. And that's one of the reasons why I strongly believe this is the reason. I haven't proven that yet. We are still working on that. But hopefully you will see that paper at some point in time, what happens to these RVs where we have used extensive myocardial protection strategies rather than fibrillation.
And any tips how one can decide whether the patient would require upfront biventricular support, or you would do a univentricular implant and then decide along the clinical course, either in the operating room or post-implant, they would require biventricular support?
Good point, because many of the times the implant strategy and the consent team talking to family will always be for biventricular. Many of the RVs are poor, but we do our best at the time of LVAD. We finish the LVAD, come off bypass, and come off with complete RV support. Irrespective of the hemodynamics and the status, we will support the right ventricle with the nitric oxide, support the ventricle with milrinone and adrenaline, optimize the ventilation, and if you think there is a doubt about the synchrony, we always pay and get the synchrony, and then make an assessment. Many of the times, we even make a measure in such a way that we don't put an ORVED, even if there's a little bit of a struggle. And our strategy to wean from bypass to LVAD is we don't go to full cardiac index. We go to cardiac index of somewhere around 2 liters to maintain the septal movement towards the RV, because we are very particular and careful about where the septum lies, how the tricuspid valve co-opts, and how much of TR is acceptable. This is only going to help RV, and we try to balance the filling of LV to some extent based on this. With that, our incidence of ORVED is much lower in the last 5 years compared to how it was before. But you are right. Some of the situations where the RV is terribly bad in pre-op, we are prepared to undertake. There are occasions where we couldn't sustain just on LVAD alone, and the RV fails immensely in spite of all the measures. So RVAD is not a bad thing. Implanting RVAD even after few days, once LVAD goes inside, again is not considered as a failure. It is a question of strategy and question of what is your acceptable RV behavior. This is about a bridge. What is the best bridge, minimizing risk towards the next definitive step of transplant? That's how I think we do. Yeah.
And then you mentioned in your series that you've changed your anticoagulation strategy and have seen changes in outcomes. Again, this is for the all the panelists here. And what has that been, and how much of a positive effect you've noticed?
I think at one stage in 2015, 2016, our neurological risk was quite high, somewhere close to 80% or 85%, which was unacceptable because that's not a justice. Every child, if develops a stroke in some form, we are not doing correct. And that's what made us think, in fact, review the whole practice and think, what is the best strategy? So we spend more time to hemostasis. We don't bring the child with open chest. We try our best in order to do those things and then start anticoagulation for these VADs as soon as we are able to. Just first few hours to monitor if there is anything at all in terms of blood loss, and then we start. And also we changed from a conventional heparin, conventional anticoagulation towards Biniwale. Biniwale has helped a lot in these children to achieve optimal anticoagulation sooner than we think it is. And then we start to add antiplatelets within 24 hours, because once you have a dry chest and chest drain loss are minimal, we can commence stepping up of all these antiplatelet agents. We always try to aim for dual antiplatelet agents and then optimize them with antitania measuring with the Biniwale. That's how we have used. Only in situations where we need to undertake other procedure for any reason, then we switch over to heparin. Otherwise, we stay with Biniwale.
Sure. And even as you mentioned, your antiplatelet is just empiric weight-based, or do you have any systems to check antiplatelet activity, or
Weight-based.
weight-based?
Weight-based.
Sure.
Unless there is a GA bleeding or any other risk of bleeding or any other problems, we stay with weight-based and just start. That's how we have stayed.
Any other experience from any of the panelists as far as anticoagulation in the Berlin VAD? I know like the Stanford group had published their own protocols for antiplatelet therapy, and has that changed over a period of time?
We agree with Dr. Nagarajan. We also follow the same strategy, but we tend to check the antiplatelet activity more aggressively. And we check it objectively, and we change our doses as per activity of the platelet inhibition.
And Dr. again, Mr. Muthialu, any experience of sending any of these patients home? There's all these new drivers coming, and any of the bigger patients, have they gone home, or most of them stay in the?
No, it is quite attractive. And in fact, we worry because they occupy the bed. And as we see, the waiting time to transplant becomes longer and longer. If you look at the NHS commissioning, how it happens in United Kingdom and the NHS commissioning for these VADs, when I was a fellow in 2006, 2008, those days, the commissioning used to talk about 52 days to 75 days as the waiting time for transplant on VAD. And now we are talking between 350 days and 500 days. And that's the reality. But in spite of those changes, we still haven't managed to send patients home yet. We probably don't have confidence. That's probably the last reason. One of the things is where to keep them, because many of them are from faraway places, and then monitoring anticoagulation, monitoring the pump function and development of fibrin clots. There are still lots of areas of uncertainty in these children. They do go out of the hospital, they go to park, they do take part in few community things, allowing children to grow. Their growth and development is vital, and they do take part slowly with a smaller active ICUS, which is very convenient to transport them outside the hospital. They walk with a wheelchair, but they've not gone home.
And how has your experience been with device infections and the cannulas, the infection from the cannulas? Has that improved over a period of time? And have you done any technical modifications to help with that?
No, I don't think technical modifications have helped in those things. Wounded functions are problematic, and quite often we see some colonization and kind of an infection around the cannulation portals, those sites where they exit the chest wall or the abdominal wall. They're the notorious ones. Sternotomy and mediastinitis are extremely rare if you take precautions well, and especially if you have a child who was sick, Intermax 1 from ECMO to VAD, they are at a higher risk for these infections, and their wound infections in the neck cannulation site or generalized bloodstream infection related to long ICU stay, lines, all that are common in these children. But mediastinitis are quite rare. But we haven't done any modification because of infection risk.
Sure. Again, thank you so much, Mr. Muthialu, for sharing all
Thank
your
you for the opportunity.
in the interest of time, I'm going to move the discussion to Dr. Biniwale. Dr. Biniwale presented a video of actually HeartMate 3 implant in a small child who was actually a single ventricle. But I just want to take this opportunity to also discuss HeartMate 3 implant in pediatric patients in general and to get some technical nuances. So Dr. Biniwale, the first question is, what weight range would you consider actually optimal for a HeartMate 3 implant in a pediatric patient?
Thank you, Dr. Sainathan, for your question, and thank you for the CTS for this opportunity to speak at this webinar. I think more than a weight-based protocol, we look at the BSA, and if the child has a BSA of 0.7 or greater, then they are a candidate. But we also rely on advanced imaging, especially a CT modeling, 3D fit modeling, which will let you know if this device can fit in that particular child.
And again, and a great 3D fit modeling here presented in your video. The question I have is that that proprietary or is that available through the device manufacturer? How just for our audience, where they, if they have to do one, where they can get that thing done for themselves?
Yes, so the manufacturers provide a 3D fit modeling for their device itself. So they have two device options, one with the reduced ring as well as the regular model. And you have to use your institutional computer software to create the thoracic cage into which that device can be fit. So if you have a 3D modeling program already for congenital heart disease, it's much easier. You just take the object, which is the device, and then superimpose it on the patient's thoracic cage. And you can rotate it in different directions and see where the best fit would be, the apical cannula positions, as well as whether there's a need for rib resection and so forth.
Sure. And again, like I'd pose this question to Dr. Muthialu. Just for the HeartMate 3, what are your tips of locating the optimal site for the apical the cannula, the drainage cannula site? And again, would this again vary whether the ventricle is a morphological left or a right ventricle? You had presented a patient with a morphological right ventricle, which was the apex forming systemic ventricle.
Yeah, I agree with Dr. Nagarajan in terms of systemic left ventricle. You use the LAD as a guide, but oftentimes these kids are redos and you don't really see the LAD. So it's a transesophageal echo guidance. The finger is usually too big for these kids, so use a hemostat or some other instrument to create an indentation, see where you are in relationship to the valvular attachments. In systemic right ventricle, you may have to go under the diaphragmatic surface more so to avoid the tricuspid attachments, and especially if there's septal attachments, it can get quite tricky for in terms of inflow occlusion. So it's trial and error method, just looking at the transesophageal echo and figuring out where the optimal position is.
And again, this is just for the other panelists. Has anyone considered just like in case of morphological RV, just to remove the subvalvular apparatus, especially if they're only looking for the bridge to transplant, just so that there's no ingestion into the cannula or any other issues related to that?
We've entertained it in the past, but haven't had to resort to it, thankfully, because it does add complexity to the surgery. And since we do most of our cannula implantation with beating heart on pump, it would add increased complexity in terms of cardioplegia and so forth. So we haven't had to resort to it.
And have you like considered like an extra pericardial implant at times that you mentioned a rib resection in order to accommodate the head, the pump head in a child where it may not completely fit within the pericardium and you need some extra space?
I date myself by saying that back in the day when we did HeartMate 2s, we routinely do subdiaphragmatic implantations or extrapericardial implantations. But with the HeartMate 3, it's a little tricky because there's not much of a neck on that between the donut and the inflow cannula. So it's a little hard to get it under the diaphragm. We haven't done it. What I tend to do, what our team tends to do, is translocate it into the left pleural space. And sometimes it's right against the chest wall, and you sometimes have to resect a rib in order to make it fit and prevent that inflow cannula from intercepting into the valve, whether it's a systemic mitral or the tricuspid. It can get tricky because the profile of the HeartMate 3 currently is quite large, but with the upcoming new models, that profile is going to decrease. We're looking forward to that.
Sure. And I also noticed in your video that you anastomose the outflow graft first before engaging it into the pump. Your preference and any reasons for that?
Well, we did that without, the patient was already on ECMO, and before converting to cardiopulmonary bypass, we did the outflow grafts. I routinely do the outflow grafts first because I do those off pump and
Okay.
limit the duration of cardiopulmonary bypass just to put in the LV inflows, so that there's minimal impact. If there's two ventricles, a minimal impact on the right ventricle, morphologic right ventricle, if it's not the systemic ventricle. And also it just decreases the amount of bleeding and postoperative complications. So I have always measured the graft from the location of the where the LV apex would be to the aortic outflow cannula. There's been rare occasions where we've had to shorten that Dacron cuff part of it, but usually it's a good fit because you put the bend relief right where you would estimate the pump to be, and then measure it out to the aorta. You can curve it into the right pleural space if the length is excessive, but it's not common to have a problem with that length.
Sure. And that was my follow-up questions. Has at any point of time you had to trim the bend relief, because in some of the pediatric patients may not have that height, and the bend relief may be a bit longer, and the graft doesn't come out of the bend relief, and you have to trim portions of it. Have you had to do that anytime?
Well, usually with a BAC of 0.7, the kids are mostly cachectic, cardiac cachexia, so they have enough vertical height, at
Okay.
least in my experience. So I haven't seen that to be a problem. And also, like as I mentioned, you can reflect it into the right pleural space, curve the
Sure.
graft so it's not vertical. That also prevents a little bit of SVC compression.
And my other question is, any tips for safe tunneling? Do you tunnel subfacially? And again, do you go below the muscle or above the muscle, or you try to keep them in subcutaneous tissue, because these are just bridge to transplant? The driveline. Just how? Any tips for that?
Yeah, subcutaneous tissue is treacherous. It always ends up dry lab infections. The wounds don't heal. The drive lines move in and out. Subfascial is more reliable, staying anterior to the muscle. Again, it's very hard in these kids with very skinny abdominal walls to do it accurately, but it's a technique, and if you do it correctly, it's successful. Sometimes you have to come below the umbilical level, because the drive lines can be fairly long in these little kids, and you have to wind them up. There's not enough space in the pericardium, so you have to tunnel them out to a greater extent, but you have to stay subfascially.
Sure. And if you have an incompetent valve, how do you deal with that? And these, would you try to replace the valve, or you try to close the valve, or what has your experience been?
Yeah, so we try to decrease bypass times and cardioplegia times. So we do the least minimal. First, we try and put a central stitch to maintain confidence, but obviously in the very small patients, there's the danger of the aortic valve ripping out and causing subsequent wide open AI, which is not pleasant to deal with. So a patch, subcoronary patch, is a quick fix, and that just takes it out of the equation. If you have trivial AI, it's going to be mild afterwards. So anything mild or more, we will fix the aortic valve before we put in the aortic cannula. And you can use the same aortotomy to implant your outflow graft, into which your cannula will go.
Sure. And Dr. Biniwale, what is your strategy been for the anticoagulation for these patients?
Yeah, usually heparin as soon as the chest tubes dry up, which is a few hours, and then we add aspirin. Some kids who are not responsive, we obviously objectively verify now for aspirin responsiveness. Very rarely they may need clopidogrel, but that's rare occasions.
In the interest of time, I'm going to move to the next. And thank you so much for all your discussions, Dr. I have next Dr. Alsoufi from Louisville. Dr. Alsoufi had presented a nice video of use of an impeller as a bridge to transplant in a patient with a failing left ventricle. Dr. Alsoufi, a couple of questions. Again, the fit testing, is that proprietary or is it through the device manufacturer?
Well, we try to do it locally. The Abiomed is always happy to help us if there's any question or concern. But we have our own protocol right now. The radiologists are well aware what we need to do, and then we do our imaging, our 3D reconstruction. They know the measurements that we need. Obviously, if the subclavian is more than 6, that's where we stop actually. But if we need to do more, then we'll do the different measurements like the aortic valve to the apex, aortic valve to the innominate, the length of the ascending aorta. So all of that is done locally with our own 3D reconstruction. We have consulted Abiomed initially, and they're always more than happy to help as well.
And as you pointed out, apart from size of the accepting vessel, in case the subclavian, is there, as you said, anything else, angulation or anything like that in a pediatric patient, which would make you choose an innominate approach versus a subclavian artery approach?
Yeah, definitely. Obviously, the size of the vessel is the biggest determinant. Usually, if your subclavian artery is large enough, by definition, probably the lengthwise, you'll be able to use the standard approach. Otherwise, I'm using the innominate artery and the access to the innominate artery. I initially started doing with a partial sternotomy, thinking that this might be the most secure and best exposure. However, in that patient, actually, that's the smallest patient that has ever been reported to have impellers support. She's a 7-year-old who's had a prior sternotomy, and I felt, okay, well, can I access it with a suprasternal approach? And that was really easy. And since then, I've moved away from partial sternotomy. So I always use a small suprasternal notch incision, a little bit oblique, and have excellent access to the innominate artery. You really need those measurements because sometimes the ventricle is huge and that's not a problem, but the length to the innominate artery orifice is short, then you probably can have a room to push it a little bit more than 5 centimeter into the ventricle and to have the outflow cannula where you want it to be. So you need to have all those measurements to adjust and customize it per patient.
Yeah. And I'm assuming that you're ambulating these patients because they are on support for a while. Any special precautions in securing these cannulas so that there is no movement and
well, obviously you need to secure it. So we use the standard, central line resin, whatever comes with the impeller, but we also use 3-points securement using the cath grips, one at the upper chest and two across around the abdomen to prevent any tension, when you transfer the patient. But they're really ambulatory. They're just like pushing the console. I have great pictures. It's amazing. Like, post-op day 1, they're starting to move around. And I've been very impressed with that.
Sure. And what anticoagulation strategy do you use for these patients?
We do the bivalirudin, similar to our other VADs. Obviously, there's a purge line for the device, but for anticoagulation, and we follow the DTT, like similar to any other VAD. If needed, we sometimes add antiplatelet. It's really standard.
And in your opinion, how long is the support is reasonable for these patients before you would, unless they're hemolyzing or something like that?
Well, we have not seen hemolysis, interestingly, and up to 105 days. I'm not sure if because they're smaller relatively, therefore, you're not using as much power to achieve the cardiac index you want, or is it because of the bivalve has improved things? So we have used it up to 105 days in that 7-year-old child. What's reasonable, what's not, I think depends on your objectives and on what you feel, it's gonna take for the patient to receive a transplant. If you're doing it for a teenager, almost adult size, that they're not gonna they're not gonna wait for a long time. I think it's very, very reasonable. Let's say you have a 28-year-old Fontan patient, that patient, even status 1A, we know that patient is gonna wait probably 7-8 months. Now, then the question, could that patient be candidate for for a HeartMate 3? I would, that would allow him to be ambulatory and even be discharged home, or it just becomes a judgment call. I have seen in those patients who had impellers for 100 days and 105 days, at time of transplant, I've seen some clots coming off, and it definitely makes me nervous, but we've seen that also with the HeartMate 3 or with the Berlin. So it's not perfect. I have not seen any patient who had any stroke or limb ischemia. And as for the hemolysis, again, as I told you, we haven't seen. The only time we needed to do transfusion in our patients was in one patient who had a GI bleed, obviously related to the pump, but not related to the pump's choice, and had ulcer that needed to be cauterized, and obviously we had to adjust the anticoagulation to control the bleed. That was the only patient who needed transfusion in our experience.
I have Dr. Bishnoi. I think he wants to make a comment or a question.
Yeah, it is a comment on Impella. We also have 2 patients right now who are on Impella, and one patient we have supported almost for 4 months on Impella now, and it is a pretty good pump. And as we are using it more and more, and we are becoming more comfortable with it. And on the other hand, like in one of our kid is a single ventricle who is an Impella right now. And another advantage of Impella is that you can support them with minimal invasive. Dr. Alsoufi said that when you are still family is debating whether to go for a VAD transplant and patient is very marginal, you can support them. They will become a good candidate for HeartMate 3 later on. So now this other kid is single ventricle being supported on Impella, and now because this kid is now a candidate for heart and liver both, and the waiting time for heart and liver is much longer than isolated heart. So we are thinking of converting to HeartMate 3 now. So I think Impella is coming slowly into the pediatric practice. As we understand this technology better and better, I think use is going to go more and more frequent.
Yeah, I just have a quick question for Dr. Alsoufi. Have you noticed any RV interactions, especially in the smaller kids, when you have higher impeller speeds? If you go P5, P6, there's a septum being shifted to the left and RV failure as a result of the increased flows through the impeller. So have you had to run them mid-speed? And if so, do you need to ramp up your anticoagulation for these patients?
Yeah, I've seen it in one patient, and in retrospect, this patient also was. I've had a few patients that we were thinking preoperatively that they might be, they have marginal RV, and that we might need to support them. We were prepared to support them with an ECMO for briefly, or with an RVAD briefly. And actually, we were able to, as you said, you have to adjust your flows and add some right heart support. And we escaped that. There was one patient who had a prior heart transplantation 8 years earlier, and was having vasculopathy and end stage rejection and diastolic dysfunction, more so than systolic. And those are the patients who are very challenging to support with regardless of the type of device. And this is the patient we struggled with the most. And I ended up needing to put, and at that time, I don't know what's the experience right now, but the Impella told me that the first child who received BiVAD support with 2 impellers, and we had to add the Impella, and it was actually a challenge to adjust the flows as you might expect. And I think more so because of the diastolic dysfunction as opposed to the systolic function. As you know, even with any type of device, I want to say that even though he was bridged eventually to transplant, he was not the best supported patient, and it was challenging. But yes, similar to any VAD, you need to adjust your medications, adjust your flows to just figure out where the heart, where the right heart sits and how you balance circulation. I have not needed in it as a bridge to transplant to add an ECMO support. Also, although I've had ECMO plus Impella, what people call Impella for myocarditis towards recovery, and I've had a couple of those patients.
Thank you, Dr. Alsoufi. I just would like to ask a few questions with Dr. Zimpfer. We are reaching the top of the hour. Dr. Zimpfer presented a video of a novel Fontan assist device based on the Berlin system with a special modified Berlin cannula. Dr. Zimpfer, a few questions. Have you used, I know the videos which you have presented are in acute situations. Have you used in a variety of other situations as a bridge to decision or a bridge to recovery for these patients, or for some chronic states like protein-losing enteropathies or something, for some sort of recovery with that device?
So thank you. Well, our experience locally is 2 cases. So we have one patient who was rather an acute patient who we implanted after he went, it was a single ventricle patient after Fontan who had an ascending aortic procedure and later low output, and he was from an outside hospital. And the second one we did was a chronic patient who was implanted for PLE.
In your opinion, have you had any experience of like the PLE getting better or the FALD getting better and making a better decision if they're isolated organ transplant candidates compared to like dual organs? I know this is very limited experience you've had with the device so far.
Well, the PLE seems to improve. So there's not a lot of experience as you point out. I think there is now somewhere around 20 patients all over Europe with different indications with this cannula, but the cannula itself seems to do the job. So the PLE seems to recover, the liver function seems to recover in these patients. Also, when they have ascites, that seems to recover, so that the cannula does the job in reversing those typical Fontan-associated issues.
And if you're using it for isolated subpulmonary support, what is your anticoagulation strategy for those patients then?
So we always use Biniwale at the moment, somewhat depending on how big the patients are. We will then switch them to Coumadin, and we run them on the same protocol that we use for the regular Berlins.
Again, just a broader question for our other panelists. Has anyone had experience with this cannula in the US?
No.
The other question I have for Dr. Zimpfer is, how do you run if you're going to use it as both subpulmonary and subaortic support, do you run the Berlins any different than, for example, a biventricular support Berlin? I know you presented some hemodynamic data. Are they any different between the two?
Right. So we only have experience at my center. We always did biventricular support setup, and then you run them very similar to what you will do with the BiVAD, but try to keep the flows low in order not to congest the lungs that are not used to high output going through the lungs. There is a limited experience also with implants as an isolated subpulmonary support. What the centers did was to really very gradually increase the pump output, again with the idea not to overpump the ventricle and the pulmonary vasculature.
The final question I have is, has any of these patients gone home with, especially if they're isolated subpulmonary, have they gone home with a portable driver or anything like that?
They go to the normal ward, and they come into a state where they ambulate through the hospital. But the current driver, the active, you're not allowed to discharge patients in Europe. And so what some centers did to discharge them to a living facility very, very close to the hospital, but from the IFU and from a legal standpoint, we're not allowed to discharge them. So we have to keep them in the hospital, which is always difficult, because they will in Europe currently they will wait for more than a year.
And a final question is, I'm assuming that you could implant this device in even the older types of Fontans. It just required some sort of modification and interposition grafts to achieve the support.
Yeah, so the way the cannula is designed, it's plus minus a reservoir, and you will have to modify it to implant it. So the cannula requires grafts that are attached to the cannula, and then again the grafts are attached to the veins.
I guess we have reached the almost the hour, and I have two questions, Q&A questions. One is for Dr. Bishnoi. One of our audiences has asked them what antiplatelets do they use, I guess at Stanford, I would assume, and how do you check their activity? Do you use point of care, or do you use a central hematology lab?
We use aspirin and Plavix, and then we always do a platelet inhibition test. I don't know exactly what type of test is done, because that is followed by our heart failure team, but it's not a point of care test. It is done in our central lab.
Sure. And the second question is, I think it's not directed toward anyone, but it's the question about experience in VAD as a bridge to recovery. I think Dr. Muthialu Mr. Muthialu had presented some of his data, and also I think Dr. Alsoufi had mentioned, and maybe Dr. Eghtesady also in the beginning. How often do we see any opinions from a panelist?
I'll say that we've had, it's been rare, but we've had probably a total of like 3 patients in the last 10 years. So it's not a large volume. And it seems like these are patients typically that have some version of myocarditis or something, as opposed to underlying genetic pathology or cardiomyopathy that is irreversible. It still was, like the last patient we did, which was probably about 5-6 months ago. She was supported for, I want to say like 4 months, 5 months. We haven't had the experience that has been described in the past, like the Harefield protocol, where aggressive medical management and things like that to bridge to recovery. But and the single ventricle, I've had occasional patient. I remember 2 patients one patient who presented essentially in shock, went on ECMO because had a arch obstruction that had not been appreciated. And we put a VAD in that kid after fixing the arch, and that kid recovered and went on and completed both the Glenn and the Fontan, ultimately. Same another hypoplast that didn't crash or anything like that, but there was evidence of ventricular dysfunction, and there was a lot of concern about that patient, whether we, what should we do? Should we address the arch and everything? And then the arch was stented, and we put a VAD simultaneously, and that patient ended up also being able to go on. So we've had a few patients, but it's not a large number. That's our experience.
Thank you so much, Dr. Eghtesady, for the comment. I guess we have reached the end of our webinar. It's almost an hour. Any closing comments from any of our participants?
I think we've discussed this at length, but I just want to bring up the psychological factors that go into putting a VAD, especially in an adolescent, and the body dysmorphia that develops from that. So psychological support during this period of time is essential, because these patients do develop a lot of problems especially the kids with in the past, total artificial hearts had a huge problem with that. So just want to put it in. It's not a surgical piece, but it's very important.
Sure. Thank you so much. I guess again, I thank everyone for all their excellent videos and contributions. It's not easy because some of these implants don't happen. They happen, very not that often, and it's not easy to like have videos, a variety of videos. And I thank for all your expertise and your participation. And I think this would conclude.
Thank you for attending the CTSNet Guest Editor Series webinar. As a reminder, a recording of today's webinar will be available this week on ctsnet.org and CTSNet's YouTube channel. We encourage you to take a moment to fill out the brief survey that will appear on your browser upon leaving this panel. Your input is greatly appreciated, and we want to hear of any CT surgery-related topics you'd like to see covered in the future. Please look forward to future Guest Editor Series to take place in the coming months. Have a wonderful rest of your day.